It's now 1:02. And so and I just received the agenda again. So I'd like to welcome everybody to the November Georgia Board of Public Health meeting and ask Dr. Rodriguez to call the roll.
Thank you, Dr. Curran. I'll go ahead and start calling the roll call. Dr. Curran?
Here.
Dr. Cheek?
Present.
Thank you. Dr. Mercer?
Here.
Major General Carden?
I'm here.
Thank you. Mr. Harper? Dr. Shin? Mr. Walker?
I'm here.
Thank you. Dr. White? And myself, present. We did not have a meeting in October. The last minutes that we have for approval would be September. I think they were sent out electronically, but I don't believe that we had enough response. So if it's okay, Dr. Curran, we'll go ahead and submit those for approval. And I could have a motion for approval for the minutes in September, or any changes or discussion.
So move.
Second.
Second.
Hearing no one opposed, those minutes stand approved. Thank
So
you all.
Mitch, I see on my board here that Mr. Dobard, Dr. Shin are here. I didn't hear them say they were here, but
Okay, I can mark him as present.
Yeah, I'm sorry. I had a hard time logging in through Zoom with a new link.
Thank you.
thank you very much. Dr. Toomey.
Yes, thanks so much, and welcome, board members. It's really nice to see you. Last month was a busy month with a number of things, both legislatively and otherwise. We actually already had a hearing with the legislature about some of our public health programs, including PrEP and other HIV programs and congenital syphilis. So it's already starting up at a fast pace with some of our most important programs from my perspective. I wanted to just take a minute to reintroduce, to those of you who haven't already met her, Dr. Stephanie Bialik. She's our new medical and clinical director who joins us after an illustrious career at CDC. And I'll let her introduce herself to you because she can do it better than I. But we are very, very grateful for her leadership, and she's already stepped up in a number of areas, including the lab. So
I'm very excited to be here. I'm an internist by training. I did my residency in primary care medicine at Emory. I did a preventive medicine residency at CDC and actually did my practicum year here at the Department of Public Health back in 2002 and 2003. And then as Dr. Toomey said, I spent a number of years at CDC, primarily in infectious diseases. And I started just a month ago, so I'm settling in and look forward to meeting you and working with you in the future.
Oh, thanks, and welcome aboard again. We really appreciate your leadership already, so thank you. I wanted just to very quickly talk about our agenda because it's pretty eclectic and action-packed, and kind of where it came from. Because the feedback I get from you, either as a board or individually, as board members reach out to me, really does influence what we put on the agenda. We've had a number of calls, and Dr. Cheek got me engaged, and Dr. Bialik will be engaged with an AAP call monthly. And much of that discussion was about vaccinations, but also what's happening with the respiratory virus this year, and what are we seeing? What are our trends this year? And I'm not going to jump the gun and tell you the answer. I'm going to let Dr. Drensick do that. But I think it's an important topic and one on all of our minds, particularly given the challenges we had last year and also with even pediatric transport last year. And so we're standing by and hopefully we'll be seeing not the same kind of burst of cases as we saw last year and after Christmas. But that's one of the agenda items, again, because of interaction with several of you. I had several questions, including in my own neighborhood, about animal bites. And when I was commenting to this individual with a dog off a leash who was quite aggressive, she said, what do you care about it? You have nothing to do with it. And my answer was, oh, yes, I do. And so I just wanted to make sure you all knew that, in fact, public health does have a role in animal bites, including surveillance for animal bites. And so, much to her surprise, I did have an interest and told her so. Moving along, I mentioned to you a few weeks ago, we were contacted by the CDC Foundation that was very generous in getting us a grant proactively around drowning. And that was such an unexpected gift from the CDC Foundation. I wanted to let you know about that, as well as our car seat program, which is a partnership with the Governor's Office of Highway Safety, and is still doing tremendous work in the districts to ensure every child who leaves the hospital has a car safety seat. And last but not least, we're saving it for last because I know so many of you, and particularly Dr. Mercer and Dr. Cheek, had an interest in congenital CMV infection and what we're going to do about it. Well, our advisory committee has spoken, and we will take action, and you'll hear about that today as well. So before I will have to slip out, as Dr. Curran said, a little early, but I do want to say, particularly since this is the last board meeting we will have formally before Christmas and the New Year's, please, if there are any issues that come up you need some help with, let me know, we can help. And by all means, as we plan January's board meeting, let me know so we can ensure to have another action-packed agenda. So thanks so much, and I'll turn it over to Sherry for her usual extraordinary epi update.
So Kathleen, we may ask if anybody has a specific question for you right now, given that you have to leave early.
They know how to find me.
Having seen none, Dr. Drendick, welcome.
Well, thank you so much. Thanks, Dr. Toomey, members of the board. It's a pleasure to be with you again this afternoon. For our EPI update today, I want to talk a little bit about respiratory virus season. Can I have the next slide, please? So again, as we're very well aware, infectious diseases are unpredictable, ever-changing. Every season offers us a new opportunity to learn. Because we have a robust surveillance, particularly molecular or genomic surveillance and epidemiologic investigation, we really can continue to develop scientifically founded prevention and control strategies. So how can we use that information, surveillance and EPI, to answer the question, what will our respiratory virus season look like this year? And what can we do as far as interventions and prevention measures? So next slide, please. Well, one way to look at the possibility of what this season will look like this year is CDC has recently developed a relatively new center that looks at forecasting for infectious diseases and allows us to think about ways that this can help us both drive surveillance and target interventions as well. So the question is if we think about last year, we had what was called a triple-demic. Now, what that means is that there was really a concurrent outbreak of both RSV infections, influenza infections, and COVID on top of that. And really, the co-circulation of those three viruses impacted each other and really led to a lot of healthcare capacity strains last respiratory virus season. So will we have another one this year? How will we know? Well, CDC's forecast so far, as you see on the slide, basically their experts believe that their mathematical models are now pointing towards essentially having a very moderate COVID winter season because there is such a strong and widespread population immunity from both natural infections and vaccines, and really a more typical moderate flu season and RSV season as well, kind of going back to kind of pre-pandemic characteristics. That's what the models point to. So how do we know essentially if these models are going to pan out, and what does it really mean? So ultimately what we need to do, and if we can look at the figure on the right, ultimately what we worry about and what this figure is trying to show is that because we have the circulation of RSV and flu kind of in the bright blue on the bottom at relatively moderate levels, when you put COVID on top of it, no matter what, even at moderate COVID levels, it can really push up the sort of overall numbers and overall activity for respiratory viruses to even seasons that are representative of kind of bad seasons or high seasons, which you see here, but never really as high as that top line, which is the Omicron peak of January of 2022. So ultimately, when we look at these three viruses together, what's most important is that we really start taking a view of all three together because they impact each other greatly. And even as COVID numbers are really decreasing, when you put it on top of the others, we really can still begin to have some healthcare strains, and it helps us to design interventions better. So next slide, please. So what do we mean by looking at all three of these together? This is what we call sort of pan-respiratory virus surveillance. And CDC also has recently released a really nice website where you can look at these three viruses together. This is the national view. And I just want to point out a couple of things on this graph. Ultimately, we are looking at, on these graphs, all three viruses together combined. That's the top black line. And these are emergency department visits. So let's look at the one on the left. And I want to draw your attention all the way to the right of this graph. The very end, the right-hand side of the graph represents the last few weeks, essentially, of activity. And what you can see there, the gold line is COVID, and it's coming down really consistently. We're really seeing decreasing COVID numbers. And if you look at the bottom, the RSV and influenza activity is rising slightly, right? You see those all kind of coming together. And it looks exactly like I just described. Even though COVID numbers are really decreasing, the impact of that still being higher than the rising flu and RSV, sort of puts the overall activity level higher. And then the next question then, okay, so we realize we have to look at all three together, but on a more granular level, to make a difference in prevention, it's important to look at, well, who's most being affected as far as by age group in these emergency department visits. And by far, you can see on the graph at the right, the highest contributor are young children 0 to 4 years of age. That's that dark purple line that you see. Really that and continues to rise. And so when we think about that, we realize, so who's being seen in EDs for respiratory viruses? It's the young children. And so that's likely the RSV influenza contributor there as well, and helps us to think about targeting RSV prevention to that group. Next slide, please. This is our data in Georgia over the last few weeks. So we really see the lines actually are different colors. I hope that's not confusing, but we really are seeing the same thing. Look at the red arrow. The COVID numbers are in blue. They're dropping drastically, right? COVID numbers, this is ED visits as well, but RSV and flu is starting to rise and sort of converging together, bolstering really the overall activity as well. Next slide, please. The next thing to think about is severe outcomes of respiratory viruses, really. So what about deaths? So we know that, youngsters are being seen in the ED for flu and RSV primarily for outpatient visits. What about severe outcomes like deaths? What's the driver there? Really different picture here. If you look at the graph on the left, that orange bar all the way through, again, from a year ago, the death driver by far is COVID. So even though we're seeing greatly reduced numbers in regards to COVID activity and COVID deaths, the proportion of deaths are almost all COVID. So, and what about who's most affected there by age? Again, and this pattern is not new. The turquoise line on the right on the graph, by far the greatest proportion of deaths as far as respiratory viruses go is those over the age of 65. So it tells us, okay, so we want to target youngsters for RSV flu prevention, primarily for outpatient visits. And again, those over the age of 65 are still vulnerable to severe outcomes from COVID, including fatal infections. And there's where we should go and ensure that we have those over the age of 65 with COVID booster. Okay, next slide, please. All right, so now let's just break those three up very, very briefly. We'll look at COVID, we'll look at flu in Georgia, and we'll look at RSV as well, just briefly. We looked at them together. Now we'll unpack them apart and see that it all comes back together again. So as you can see here, this is COVID hospitalizations nationally. And again, as you can see, if you look at the far right, the COVID hospitalizations, again, are really one of the primary indicators that we look at as far as metrics for COVID now. Case numbers really are not telling us a lot in regards to, we have a lot of testing bias, lack of testing, home testing. So really overall, from CDC's perspective, the two metrics to look at are hospitalizations and deaths. The numbers of hospitalizations are as low on the far right side as they've ever been in the pandemic. But again, even though they're decreasing and our death numbers are also decreasing over time, again, if we look at it from the perspective of who is most being impacted, we realize that as far as COVID hospitalizations and deaths, it's still those over the age of 65. And in Georgia, we're still seeing very low, decreasing numbers of all COVID indicators across the board. We still do look at cases in Georgia, although I think there's some limitations there. Our case numbers are really low, deaths are really low, hospitalizations are declining, and all of our other indicators as well. Next slide, please. So even though everything is declining, it shouldn't give us a false sense of security that things will just continue to be that way. The wild card with COVID is that the circulating variants can change rapidly and can ultimately result in high levels of transmission, surges in cases, and then again, following that, the surges in severe outcomes as well. So we have to keep a close eye, not only on those surveillance indicators, but on the variants that are circulating. This is a really interesting time in COVID landscape. Over the last few months, there have been about at least 12 or more COVID variants that are really similar to each other. They all emerge together. They all are derived and are subvariants of Omicron XBB. And they're driving all the infections in the US at those low levels. They're not new, they've evolved together, and they're not really causing surges. Pretty recently, a new, very different and highly mutated COVID variant emerged primarily in other countries, and it was called BA.2.86. And again, there was a lot of concern about it because it was so much different than these Omicron XBB subvariants. But so far, and luckily, perhaps due again to cross protection, other population immunity, we're not seeing surges due to this BA.286. And the good news about the newly available COVID vaccine is that it is derived, it's monovalent and derived from XBB 1.5. So it should be effective against all of these variants that are circulating, and is shown to have some effect even on this new one, 286, which is really still remaining at really low levels. A new one that's emerging that we're just keeping an eye on that has evolved from BA.286 is called JN1. And so far, so good on that one as well. No huge increases, but we have to I'm making the point that we have to keep even this degree of granularity about these variants in mind as we're thinking about changes in COVID and how it can ultimately impact, of course, the other two viruses and hospital capacity as well. Next slide, please. So let's just take a real quick drive through flu activity so far in Georgia, just rapidly. We're really just starting to see flu increasing in Georgia. If you look at that graph and the black circle around that red line, that's flu activity so far this year. It's going up, it's above baseline, but still the number of visits for influenza-like illness in Georgia is still just about 4% or so of all visits that are calculated from outpatient providers. About 4% of them are due to influenza-like illness. And as you can see, compared to last year, is that yellow line above it. Look how much higher flu activity was last year, and really early. This does look to be a little more of a traditional, sort of start to flu season. It's not that really high jump really early. So it looks like it may be a more typical flu season, but it's still really early to tell. So far, we're seeing kind of a half and half mixture of flu A and flu B. And so far of the flu A's, it's also early, but about half of them are H1N1. That, whether that portends for a full H1N1 season, I don't know. But so far, there are some trends that point to that. Next slide, please. So again, when we're thinking about flu, if we're looking at outpatient visits for influenza-like illness, the question then again, okay, who is most impacted? By far, we're seeing it in young children, 0 to 4, that's the red line on top, by far. But as we're also seeing in the green line below, the number of visits among younger, adolescents, younger children, older children and adolescents is rising sharply. So far, if we're looking at who's being impacted by flu, at least for outpatients, it's the young so far. And if we look at not outpatient visit, but hospitalizations, we really only look at hospitalizations in Metro Atlanta through our emerging infections program. We've had very few hospitalizations so far for flu so far this season, but interestingly, about 40% of those hospitalizations were among young adults, 18 to 49. And that might also be a trend pointing to an H1N1 season, which has a tendency to impact a little bit younger adults rather than the older, over 65. But I still think it's just a little too early to say. We have not documented any flu deaths so far this season. Next slide, please. All right, we've done we've done COVID, we've done flu. Let's just quickly look at RSV. RSV, again, can be very serious in young children and hospitalizations and even deaths. We don't count individual cases of RSV. It's similar to flu. We really look at other indicators. We primarily look at the percent positivity for tests for RSV, both PCR and antigen tests. And as you can see, we sort of look at it similar to flu, like what's over baseline. And if we look at that graph right there, the baseline is the horizontal line near the bottom. And over the last few weeks, you can see we've been well above baseline. But 2 weeks ago, we actually had 21% of tests for RSV positive in Georgia. That's really, really high activity. And it's also really early. So even though normally we would expect RSV season to just be beginning, kind of like flu, and even though, again, the model or the prediction was that this might be a more typical RSV season, I don't know, it looks a little early to me, at least here in the Southeast. But on the good news side, we had 21% positivity 2 weeks ago, but it dropped pretty drastically in a couple of weeks. And so we were around 11 or 10% positive this week. Still high, but it's starting to go down. And here in Georgia and in most southeastern states, we are seeing this early high RSV activity. It's not like this in other parts of the nation. And what happens is it'll start here and then move to other parts of the country over the coming weeks to month. Next slide, please. And if we look at just a year ago, RSV was really strange last year. So again, where that black circle is again 20% positivity on September 19th, really early, and dropped off again like a rock. I mean, went really low. By the time we were here in November last year, we had really low RSV activity because it had started so early. So we'll see how that goes. Next slide, please. I just want to draw your attention to one other thing. CDC also just recently introduced an interactive RSV dashboard based on emerging infections program data from around the country. And it's also a really nice source of RSV data that can look at activity over time. Basically, I really want to draw your attention to the dashboard, and you can manipulate the dashboard to look at, just Georgia or the nation as a whole, or, over month or week or whatever, however you, would like to slice the data. But again, where that black line, where the black circle is, these are RSV seasons previously from 2019 through now. You can see that really early one last year is right up against ours, So again, we're really having a high early season this year. But the question about that is, okay, so it's early and it's high. What can we do about it? Let's answer the question. Next slide, please. Who's most impacted? So if we're looking at severe outcomes in Georgia, this is the same CDC dashboard. Who is being hospitalized for RSV in Georgia? And this is broken down, not just for young children, but by months. 0 to 6 months old is where that black circle is. By far, most RSV hospitalizations have been among those 0 to 6 months old. But the pink line, where the arrow is 6 to 12 months old, and it is rising sharply as well. So almost all hospitalizations for RSV right now are among kids, and young kids primarily. That's important to know, simply because this is where the prevention strategies should be prioritized as far as, so the new biologics for this year. And again, I know there have been some supply issues, but I also have heard recently, just from CDC yesterday, that they're looking at the manufacturers making more of the young child monoclonal antibody for RSV. So we shall see. Next slide, please. So the bottom line is, no matter the forecasts, we started with the forecasts. No matter what, we realize that that COVID circulation and the seasonal respiratory viruses all circulating together will indeed and can have tremendous impact on populations and healthcare capacities, but are preventable. So again, thinking about all of the available prevention strategies, the vaccines that are available as recommended or as indicated for these viruses, and also to continue the ongoing surveillance with that pan-respiratory virus view so that we can see the impacts on each other, who is most affected, and can form, again, scientifically appropriate interventions for prevention and control as well. So thank you very much. I think that's my last slide. If we have time, I'm happy to answer any questions that you might have.
Thanks, Sherry. Great information again, and very well presented and sorted out for us. Any comments or questions for Dr. Drenzik? Sherry, you were so clear. There's no questions. So now we go to Galen Baxter.
Good afternoon, everyone. I appreciate the opportunity to speak about animal bites and rabies control from the environmental health perspective. You can go ahead and change the slide. So rabies is one of those viruses that get into the central nervous system, makes its way to the brain, and will eventually cause death. Fortunately, though, it is a preventable disease. And most of the cases that get reported to the CDC each year occur in wild animals like bats, raccoons, foxes, skunks. But the unique thing about rabies is that any mammal can get it. But one of the things is with smaller mammals like chipmunks or squirrels or even rabbits, if they were to be attacked by a rabid animal, the chances of them surviving that attack, are pretty low. So therefore, the possibility of transmission from one of those smaller mammals is, low to no risk. All right, next slide. So different parts of the country have different mammals that are reservoirs for rabies. Here in the East Coast, the raccoon is the reservoir we have here. Skunks and foxes are the reservoirs in the central and western U.S. But believe it or not, contact with infected bats are the leading cause of human rabies deaths in the United States. About 7 out of 10 Americans will die from rabies in the U.S., and they were infected by bats. Since bat bites are painless and in some cases even hard to detect, people can get bitten either while they're asleep or if they were to pick up a bat that they find in their home or out on the ground. All right, next slide. In Georgia, the local boards of health are tasked with controlling rabies, and the requirements around rabies control can be found in the OCGA Title 3119.1 to 3119.10. And some counties and municipalities have adopted ordinances that will delegate that responsibility to animal control. But environmental health will investigate reported animal bites if animal control does not, or if the local government does not. And while it's not as common as it used to be, some environmental health specialists will remove the heads for animals that are suspected of being rabid, and they'll ship it off to the Georgia Public Health Laboratory. And then some environmental health offices may just ship the heads that have been removed either by local veterinarians or by animal control. All right, next slide. So in Georgia, all animal bites have to be reported to public health. And what I'm going to do here on this slide is kind of walk you through the steps of what happens when an animal bite occurs. So go ahead and, yeah, there we go. So when an animal bite occurs, even if it's an animal that bites another animal or an animal that bites a human, then a report is made. And those can come either from poison control, the local medical provider, or somebody just calling in and reporting it to the health department. Once that report is received, it is entered into the SENS, and then the local environmental health office or animal control is notified. And once that happens, then an investigation will occur. And so I'm going to talk a little bit more about an investigation in just a moment. Next slide. The charts here you see on the screen are just a snapshot of all reported bites from July of 2018 to October of 2023. And this includes both animal to animal and animal to human bites. And as you can see, the majority of the reported bites are from dogs and cats. However, you can see that there's a myriad of other animal bites that have been reported. So in total, the number of reported bites within this time period were 71,715. Next slide. All right, and in this graphic, you can see that the geographic regions where the reported bite incidents are the highest. And, as you would expect, the more populated the area, the more frequent bite incidents you're going to have. And so once any of this bite information reaches the local environmental health office, the investigation begins. And it's crucial that environmental health investigate these bites because sometimes there's not a lot of information that comes in with the report. And so the environmental health specialist will have to do an in-depth search to see if they could either find the animal or animals that were involved. And then sometimes the victim, they may not be able to recall everything that their medical provider told them. And sometimes it's difficult to get in touch with the victim as well. Next slide. The state public health veterinarian and the DPH epidemiology creates and maintains the Georgia Rabies Control Manual. This here is just a cover of the 2018 version, but the manual has been revised and it is currently under review and will be published on the DPH website as soon as it's ready. This particular rabies control manual is what environmental health specialists will use to help them guide the investigations. It gives examples on what to do and what measures to take under certain circumstances. So, for example, the recommendation to quarantine a pet dog or just observe it could make the difference in saving a life or putting the pet down needlessly to test it for rabies. If a pet's up to date on all of its vaccines and then it bites somebody, the recommendation would be just keep the dog under close observation for 10 days. And then if no symptoms develop, then the animals, can be released. If the pet is bitten by another animal that's suspected to have rabies and that animal is not available to be tested, then the recommendation would be to strictly quarantine or isolate that animal for 4 months if it's a pet dog or a pet cat, and give it a rabies shot as soon as it goes into the quarantine or isolation, or at least a month before it's due to be released. During that time, the pet has to be kept in strict confinement so that it doesn't come into contact with any other animals and it can be observed closely. So if no symptoms develop during that time, then it's assumed that the animal did not get bitten by a rabid animal and could be safely released. And so we have those parameters on how long to keep a dog under observation or a pet under observation, because if they bite someone and 10 days later they die, that's a pretty good indication that they had rabies at that point. And if they are bitten and after 4 months they don't develop any symptoms, then it's safe to assume that they did not get bitten by an animal that has rabies. Next slide. So while rabies control is a function of the local board of health, this graphic just shows the importance of the collaboration between all the different agencies and entities to ensure that animals and humans in Georgia stay safe. So next slide. So if you have any questions, feel free to reach out to me as far as the environmental health side. If you have any questions specifically about rabies, you can reach out to Dr. Gobble and she can answer those questions. Thank you very much.
Thank you, Mr. Baxter. Any questions on rabies or anything else about animal bites? You guys are so clear and complete today. Wow. Lisa Dawson.
It's a good thing.
Thank you, Dean Curran. Good afternoon. My name is Lisa Dawson. Thank you to the board for your interest in injury prevention and to the Commissioner Toomey for her continued support. This afternoon, I'm going to briefly go over general data on childhood injuries and specifically the intervention efforts related to transportation safety and drowning prevention. Next slide, please. The Injury Prevention Program empowers partners to get work done at the state, regional, and local levels. We often do this by leveraging resources across organizations. Those resources can be data, training, and/or equipment. We are 100% federally funded, primarily by competitive grants. We have 14 distinct projects over 5 funders, and the funders are listed on the slide. Next slide, please. Rates of injury-related deaths in Georgians aged 18 years and younger have shown a steady increase in recent years. The injury death rate increased 33% from 16.2 to 21.6 injury deaths per 100,000 during the most recent 5-year period from 2018 to 2022. Separating on the right-hand graph by intent, we see that the rate of unintentional injury deaths and intentional homicides of children 18 years and younger increased, while death by suicide remained relatively stable. The rate of homicide deaths in particular increased 73% from 3.7 homicide deaths to 6.4 homicide deaths per 100,000 population. The burden of injury, sorry, next slide, please. The burden of injury is disproportionately high among infants and older teens. Not only do these two groups have the highest overall rates among Georgia youth, but they've experienced the greatest increases in injury death rates over the past 5 years. Next slide, please. These disparities are driven by distinct mechanisms of injury. The leading injury cause of death in infants under the age of 1 is unintentional suffocation. In older teens, the leading cause of injury death is homicide, followed by motor vehicle crashes. Next slide, please. Mapping 5 years of age-adjusted drowning death rates by public health district, the highest rates tend to occur in the southeast of the state, while the lowest are in the metro area and the northeast. This graph is examining the 5-year age-specific drowning death rates by age groups, and you'll see that ages 1 through 4 have the highest risk of death by drowning, 3.2 versus 1.2 for the state overall. Next slide, please. The reason we mapped all ages is because through an opportunity that Dr. Toomey mentioned at the top of the meeting, we have an opportunity through the CDC Foundation, thanks to her connection and encouragement. We have an opportunity to address drowning by comprehensively assessing the way drowning data is collected, reported, linked, and analyzed over multiple data sets. The objectives are to identify opportunities to strengthen the drowning data collection and surveillance in Georgia, describe the burden and circumstances of drowning in Georgia using new and existing data sources. We're going to take a lifespan approach, so it's not going to be just children, it's going to be all ages. This opportunity is for about 18 months and it'll be about $100,000. Next slide, please. In tandem with this opportunity, we will also be implementing Izzy's Law. Next slide, please. Oh, sorry, back up one for me, Frederick, will you? Izzy's Law is named for a 4-year-old who drowned in a residential backyard pool in the summer of 2022. This is Senate Bill 107, passed by the legislature and signed by the governor this past spring. Izzy's Law requires the department to develop a widely accessible and downloadable safety plan for private swim instructors based on accepted national standards. Next slide, please. The implementation of this webpage on the DPH website will include description of Izzy's Law and a downloadable aquatic safety plan specifically for private swim instructors. Additional water safety resources will be linked to the webpage. And once it's live, we will be sharing it definitely with our stakeholders, but it'll probably be a little bit more of a soft launch because it'll be going live in January, and the weather doesn't really warm up until late April, early May, and that'll be a more public and focused launch. Next slide, please. Shifting gears to talk about another leading cause of death and injury for children are car crashes. The Child Occupant Safety Project, again, that Dr. Toomey alluded to at the top of the meeting, is a project that's funded by our Georgia Governor's Office of Highway Safety. It is a statewide child safety seat education and equipment distribution program. There are regional staff responsible for geographies similarly defined by the public health and EMS districts. There are 8 of those staff. Want to thank the health directors who are helping to house some of our staff in that program. Next slide, please. In addition to providing education and equipment on child safety seats, the program is also the statewide certification support entity for 4-day technician certification and renewal. So that's all the items listed under child passenger safety technician on that slide. The program offers a variety of curricula for empowering our professional partners within their disciplines to be ambassadors for children's transportation safety, as well as how they can be a resource to families and assist with consistent approaches and terminology. An example that's not up there is our staff did a course that's appropriate for EMS personnel, appropriate transport of pediatric patients in ambulances. Next slide, please. The way the program is able to serve the public across the state is in partnership with local organizations who host our mini grant program. Generally, we have 1 grant per county. However, sometimes the geographic, cultural, and density considerations impact that approach, and we might have to have 2 in a county. These grants are secondary to any other distribution program that might be going on in the county, like a court offender program. Next slide, please. For those that don't know, 3 out of 4 child safety seats are used incorrectly. Our infants are best protected at about 86% correct use. However, as children get older, appropriate occupant restraint gets worse. Safety advocates recommend good, better, and best. Our law is good. Extended use of child safety seats is better, and keeping kids in the back seat until 12 with the additional devices as needed to assist the seatbelt is the best. Next slide, please. For the federal grant period in 2023, the program distributed 5,200 seats, provided education of an hour or more with the caregiver, also had the caregiver demonstrate, learn, practice, explain to back to the instructor, and that's how they learned how to, or were empowered to utilize their car seats correctly. The program's proudest accomplishment is being able to track seats involved in crashes. Thus far, we have been able to document 412 potential lives saved. And next slide, please. Welcome any questions, or if anybody would like to know more about our programs, please feel free to reach out to me.
Thank you very much, Lisa. Any questions or comments for Lisa? Lisa, why are homicides going up so fast?
Oh, so many reasons, Dr. Curran. Access to lethal means might be one of the issues that we're looking at, but we need to take a deeper dive into the child fatality review data to really take a look at that. Could also be better reporting to DFACS.
Are there any other questions? Thank you very much. Now, Melanie Morris will talk to us about congenital CMV infection.
Hi, everybody. Thank you to Dr. Toomey and for the board members for inviting me back, and also for your continued interest in congenital CMV. So next slide, please. You all may remember this timeline from my last presentation in August. I'm very excited to show you kind of our update, and I'm even more excited to see kind of what this timeline looks like in the coming months, in the coming years. So as you may remember, this all kind of began in 2018 when Georgia Academy of Pediatrics presented a formal request to the Newborn Screening Genetics Advisory Committee to consider CCMV screening. So kind of skip over all of these, very important, but you all probably remember this from the last meeting, where ultimately it was decided based on, the current scientific status of sensitivity and specificity of the blood spot, not to add it to the universal, or not to add it to the blood spot panel. But in this bottom right corner, you'll see this red circle around it. In September of 2023, the CCMV working group did make a formal recommendation to the Department of Public Health to add a hearing-targeted CCMV screening within the rules and regulations. So I'll tell you a little bit more about it. It is going to be, so it's a hearing targeted, meaning that if the baby fails that initial hearing screening at the birthing facility, so whether that birthing facility is doing one screening and then discharging them on for additional testing, or if they are doing a repeat screening at the hospital, either way, the recommendation as it currently stands is that they do testing before they leave that birthing facility, whether they fail that first one or that second one, but at the birthing facility. So trying to capture as many of those infants as possible before they leave the hospital. All right, next slide, please. So I feel like anytime I come back and talk about CCMV trends, we're gonna just see this list continue to grow on the right-hand side. So I just wanted to show some updates since August. 2 more states have now added hearing-targeted CMV screening. So point of care, so at the birthing facility, to their rules and regs or to their codes. So Texas, they just began in September of 2023, and then Louisiana was just voted in. So we are going to continue to see these trends, I believe. Next slide, please. So I want to kind of bring this back to like big picture. So our goals at DPH regarding CCMV are, one, to educate medical providers and caregivers. So we are continuing to do that, and I'll share a little bit more about that. And then as part of this, since this recommendation is to do a hearing targeted CCMV screening process, we really want to make sure that we have, first of all, accurate hearing screening testing at the hospital so that we're not over testing and over referring for additional testing, and just improving access to this diagnostic testing. So those are going to be kind of intertwined. Next slide, please. So we've done a lot. So being part of Department of Public Health, we have a lot of amazing partners, and we've just been all over the place. So we had a speaker come and speak from the Collier Center in Dallas to a group of pediatric audiologists at the University of Georgia, all about CCMV. We had educational materials available at the OBGYN educational meeting. And I just spoke at the Georgia Academy of Family Physicians conference on Friday. And then we have a couple upcoming scheduled events that I'm really excited about. So Dr. Paula Harmon, she's an ear, nose, and throat doctor here in Atlanta, and she is the early hearing detection and intervention champion with Georgia Academy of Pediatrics. So she has graciously agreed to host have a webinar through Georgia Academy of Pediatrics about CCMV. And then we have EDI coordinators, or our early hearing detection and intervention coordinators, located across the state. So we have one EDI coordinator in every single health district. And so we are bringing everyone together for a training in April where we will touch on congenital CMV, as they are sometimes kind of maybe one of the first people that contacts the family after a baby fails the hearing screening, just so that they understand kind of the risks of CCMV as it relates to hearing. Next slide, please. And then as this ties in to hearing, we have a child health audiologist that's coming on board December 1st. So we have selected that candidate. We're very excited about that. And they will really be they'll play a critical role in these two projects that you see. So we are going to be expanding some of our newborn hearing screening training curriculums to include CCMV education. And they're really going to be working directly with those hospitals on hearing screening, but especially if CCMV does end up, if this rule and reg does kind of move forward, then they will also help support that hospital, kind of roll that out. And then we have an OAE screening or hearing screening project, so otoacoustic emissions hearing screening project. And this is really just going to help monitor even just school age kids. So just a wide range of children be able to monitor their hearing status. And so we are looking to kind of expand access to that hearing screening, not necessarily for the babies, because we already have a really, pretty exhaustive kind of infrastructure for newborn hearing screening, but for monitoring as children get older, which is a really critical part of CCMV because there is such a high risk of progressive hearing loss or even, maybe even being born with normal hearing, but then ultimately developing hearing loss. So this is going to be a big part of this project. And so we've selected the equipment, we're developing our trainings and our protocols, and we anticipate having this hearing screening equipment in the hands of health departments as of summer of 2024. Next slide, please. And I'm sure you all have questions. So any questions, I'm happy to answer.
Thank you very much, Melanie. Questions? I'm anticipating
excuse me.
pediatric questions that you had, OBGYN. Go ahead, Dr. Cheek.
First of all, sorry, it took me a second to unmute, but I just want to say thank you. This has been certainly a very long ongoing project. Dr. Mercer, I think, initially got the ball rolling, and we've all sort of championed it to try to get some things happening. And I know your committee worked very hard considering all the aspects. So just want to say thank you to your committee and to Dr. Toomey for listening and really working through this and making a decision to look closely. And I'm delighted that looking closely has provided the opportunity to have more children screened and recognized early in Georgia. So just wanted to say thank you to the department and to Dr. Toomey for making this happen. Thank you.
Yes, thank you. And I will pass that along to our amazing CCMV working group. I know that they are incredibly passionate about this and equally as excited. So thank you.
I'd like to thank Dr. Cheek and Dr. Mercer, Dr. Rodriguez. And this is an example why it's so important to have informed, experienced, and intelligent clinicians in pediatrics and OBGYN on the board to deal with these kind of MCH issues. So thanks to all of you. Any other comments? Dr. Mercer?
Can I ask a question? Yes, thank you so much, Melanie. This has been wonderful, great direction. I am slightly confused. We recently had our quarterly meeting of the executive board of the OBGYN Society, and I'm not sure about the report. If a newborn fails the newborn hearing screen in the hospital, at what point are they tested? So are they tested in the hospital or are they referred for testing?
So for the recommendation, so let me back up too. So this is a recommendation that's been made to DPH. And then at this point, we're meeting with community partners, just like we met with the OBGYN Society. And we're meeting with a variety of other community partners just to kind of look at the verbiage to make sure that everybody kind of agrees with the way that it's stated. But the way that it is currently written, and I feel very strongly about it staying this way, is that they will be automatic, like that they will be tested at the birthing facility. They will not leave the hospital. The rule and reg as it's currently stated is that once they fail that initial hearing screening, that the hospital will put in the order and do the testing at the hospital or mail that specimen off, but that child will be tested at the point of care.
Okay, great. Thank you so much. I just wanted to clarify that. Thank you.
No, it's a good point. And some states are, I mean, not many, but there are a couple states that are just like recommending testing or having them do it through their pediatrician. And I just know how hard it is to capture. It's a captive audience when they're at the hospital. And it's also such a time sensitive thing. So it has to be within 21 days. And there's no way that I think we could do this with letting them leave the hospital without it. So.
Thank you. I totally agree with you. Thank you.
You're welcome.
Any other comments for Ms. Morris? Any more comments from the board on anything?
No, I just want to say thank you to everybody for your presentations. They were very informative and so very relevant, especially beginning the flu season and RSV and all of that. I just went and had my COVID shot Saturday and my RSV shot. So I'm up to date. Thank you.
I had all 4 of them, and I got the unreported virus anyway. It was neither RSV, flu, nor COVID. So thank you, Mr. Walker. Do we have the next meeting, I believe, is December 12th, also online. Do we have a motion for adjournment?
So move.
Second?
Second.
All in favor?
Aye.
We'll see you guys.
Thank you.
All right, thank you, everyone.
Thanks, everyone.
Thank you.
Thank you.